Good afternoon, everyone. This is Susan Connor from the Early Intervention Training Program. Welcome to our Wednesday afternoon webinar. This afternoon's topic is early identification of autism spectrum disorders, why it matters, and how to support families. We are thrilled to have with us today Dr. Cutler, who is a developmental pediatrician with the University of Illinois at Chicago. And she'll be sharing with us information on this topic as we go through the next hour or so. For those of you who haven't joined before, we will have two moderators for today's session. Maria Maddox is a consultant with the Early Intervention Training Program. She is in sunny Springfield today, and she will be monitoring the chat box, and you'll hear her in just a few minutes, as well as myself, Susan Connor. I'm the Assistant Director of the Early Intervention Training Program, and I'll be here also monitoring the chat box and be available to answer any questions that may come up.
Hi, good afternoon, everyone. Thanks for joining us today. It's a beautiful day in Chicago, and the weather map indicates it's a beautiful day all over Illinois. So I thank you for taking the time to be with us. I hope that today's session will be helpful to you in becoming more aware of the early signs of autism spectrum disorder, as well as the benefits of early diagnoses, to help you gain knowledge of autism screening guidelines, the benefits of this, as well as the limitations, and to have an increased understanding of how to present the need for screening, and especially any concerning results, to the parents and how to support them through this process. Oops. Sorry, I'm on a new laptop here and I'm just taking a minute to get used to this technology, so bear with me. As Susan already mentioned, I'm a developmental pediatrician. I would also like to let you know that I'm also the parent of a young man with autism spectrum disorder. And as I speak today, I'm going to be trying to present a perspective of a parent and many of the parents that I've worked with over the years, as well as some of the standard dogma that you might hear from a developmental pediatrician. And I have no conflicts of interest for this talk. I've had the pleasure of working in early intervention for over 30 years and working in Illinois for over 20 years. And I've really enjoyed working with early intervention providers, and I'm so grateful to all of you for the good work that you do, your efforts to get families in for medical diagnostic sessions. I know that's not always easy, and to support them through this process. But I do often field questions from some early intervention providers and early intervention service coordinators regarding whether or not this is really necessary at such a young age. After all, early intervention is not a medical model. Kids get services based on their need, often as a percentage of delay. And even as they transition to early childhood programs, special education services, no specific diagnoses beyond developmental delay is required. Okay, so why go through this process and why do we upset parents necessarily? So I'm going to bring you a couple of stories today. I'm going to start with Zack's family. Zack was a little boy who I met about 16 years ago. It was a very challenging situation. The parent was single, a recent immigrant. She had endured domestic violence. And then she had this child who was almost 3 at that point, extremely dysregulated, still nonverbal. I can still see this kid just running back and forth in the examination room, screaming at the top of his lungs, the mother talking nonstop when she wasn't crying. That was the situation we were presented with. It was very clear as we went through the evaluation that this child was going to meet virtually every criteria for autism. But the question was how to support the parent through that process. We were really worried with all her stresses that she already had as to how she might react. So we had a very wonderful service coordinator in the early intervention program who worked to add a social worker very quickly. Actually, she got a social worker in the home the next day for this family, and that social worker visited the mom 3 or 4 days in a row after she was given the diagnosis of autism spectrum disorder in order to provide the supports that this parent really needed and starting to understand this diagnosis and to move forward. Obviously, that level of service intensity couldn't continue, but it was a wonderful beginning. However, this child was still pretty dysregulated. He didn't have much time when he left early intervention, and he still didn't look so great at this point. And the early intervention providers never really got to see Zack's outcome, so I'm going to share it with you now. This mother worked very hard to access different community services, educational programs, private insurance eventually she was able to obtain, and she got a very intensive behavioral treatment program set up for her child initially. She learned a lot about how to introduce strategies in the home to keep this child calm and regulated. Now, at 18 years of age, Jack still has severe autism. He has intellectual disability, but he has reasonable self-regulation. He is generally a happy teen, and he shares many good times with his mother. His mother went on to become a professional in this field, and as you might imagine, she is a tremendous advocate. And if you're ever walking along the beach in Chicago, you might run into that family. Okay, there they are. Okay. All right, so I have another story that's a little different. Benny was a little child that I just saw in the past few months. He was one of these very healthy and cute kind of big bruisers. This kid, about 2.5 years of age, looked like he was going to be a future linebacker for the Bears. He met criteria for autism spectrum disorder, and the family followed through with our recommendation for genetic testing, which revealed a deficiency, a chromosome deletion called PTEN. And this particular deletion not only can contribute to the development of autism spectrum disorder, but it also drastically increases a child's risk of developing abdominal and pelvic tumors. This child has now started serial ultrasounds periodically in order so that if he starts growing a tumor, it can be identified early and he can be saved from what could be a very dire cancer prognosis. The parent feedback regarding this situation was, you probably saved his life. But the early intervention team isn't aware of this because genetic information is often kept private within the families and their medical providers. And the early intervention team doesn't get this very positive feedback to know what a difference this can make for families. Okay. So we know that autism, a diagnosis of autism, is based on a pattern of developmental and behavioral signs, and that this diagnosis may have an underlying medical basis, as in the case of Benny. And it can be very important for families to understand that so they can implement appropriate health strategies or family planning if that is the case. And also, as in Zack's case, specific strategies and intensity may serve to enhance outcomes for that child. In Zack's case, I think the quality and intensity of services that this mother learned to leverage and even administer herself over time really has contributed to this child, who, as I said, was very dysregulated, has contributed for him being able to remain in the home instead of having to have a residential placement. So working with children with autism spectrum disorders can truly take a village. Okay. For those of you who are not yet familiar with some of the research regarding evidence-based interventions, I want you to at least be aware of this one key study because I think it explains why parents are often pushing for more intensity. That's not to say that all children need lots and lots of hours of services, but I want you to understand what parents are reading about and why they're coming from this perspective, and that there are indeed some children who do warrant intensity of services. Okay? This study, which was published in 2010 in Pediatrics, looked at almost a few hundred children with autism spectrum disorders who were diagnosed during the age of 2 years. They were given standard early intervention services in their state of Washington, and about half the kids in the study, the intervention group, were provided with an intensive 20-hour per week sessions of applied behavior analysis and relationship-based treatments, combination of both, as well as the parents being taught to provide an additional hour, 5 hours per week of instruction. These children made incredible gains. I've just highlighted the IQ gain, but their speech language dramatically increased, their behavioral problems lessened, and so on. The children who were getting early intervention services, and in the state of Washington, these kids were getting an average of 11 hours of early intervention. They also made gains. The gains just weren't nearly this dramatic. So parents read these studies, and it really causes them to feel as if they need to have this level of intervention. And yet, our systems can't always provide that level of intervention. This is very expensive. So we really do need to think about how we can use that it's a village approach to leverage the services that we can provide in early intervention in the school system through private insurance, through great community resources like the TAP resource centers and other sites, parent advocacy programs, family support. All of these can help give a child more intensity. It's not always about the direct hours with the therapist, as you know. All right. Okay. So I think that all of you know that autism spectrum disorders are very common. The most recent data indicates a prevalence on average of 1 in 68 in this country. 1 in 42 among boys. And although we can accurately diagnose autism at a very young age, and symptoms may present very, very young, as early as 12 months of age for some children, the average age of diagnosis in this country is still at 4 to 4.5 years. I think it's just really incredible, and all of us who work in early intervention, I'm sure kind of just blown away by this, that these kids, about half of them are totally missing the great therapies and supports that they could be getting through the early intervention system. The kids who are most likely to be diagnosed late are the usual story with healthcare services, the children of color, children who live in poverty, children who are born into immigrant families where English is a second language, children who may be rural and have less access, and also children who have other impairments. Autism may be overlooked because everyone's so focused on the motor or the sensory issues for a particular child. So this disorder is very common, and we always have to be on the lookout for it. We all know that autism is a neurodevelopmental disorder in which 2 main domains are affected: social communication and the so-called category of restricted, repetitive patterns of behavior, interests, or activities. And that symptoms must be present early in life, and they must be significant enough to impair functioning. Okay, so let's talk about social communication a little bit more. For this particular domain, children have to meet all 3. They have to have difficulties in all 3 of the bullet points listed here in order to make a diagnosis. So let's look first at social emotional reciprocity. And what I'd like you to do here is think about a 4-month-old baby. Okay, for those of you who are in early intervention, think about a very young child. Those of you who are parents, think about your babies at that age. And I think about 4 months old as a pediatrician because when I used to do primary care, I loved the 4-month-old well child check. And the reason I loved it is because those babies weren't yet old enough to have developed stranger anxiety, and yet they already had a lot of social emotional reciprocity. And as their mothers laid them down on the examination tables, I was able to lean forward, smile at them. They'd smile back if they were well fed and rested and whatever. They'd smile back, I could coo, they'd coo back, and we could have multiple circles of communication. It was all very easygoing and natural. I didn't have to structure the situation. This is not present for children with autism. It's not that they never have social emotional reciprocity, they do. But is it as easygoing and natural as you typically see even in a young infant? No, it's not. You often have to support it. They don't initiate social emotional reciprocity as much as they should, and they have difficulty in maintaining it. So you might get a glimmer of a response here or there, but again, it's not that natural, fun process that we're already seeing in a typical young infant. And along with that, that nonverbal communication is suppressed. It's just not developed as it should for children with autism spectrum disorders. So that the baby who's responding isn't saying any words. Often that's the marker that parents are initially so concerned about. He's not yet talking, he's not saying enough single words, not doing 2 words together, whatever. But those of us in early intervention knew that it's that nonverbal social emotional connection that is just such an important precursor to all that. So again, our 4-month-old child is already able to exchange facial expressions and some verbalizations, the cooing. And then an older infant will bring in more nonverbal behavior, a variety of gestures. It's amazing how much the typical 12-month-old child will gesture, even if they haven't developed formal gestures like pointing yet. They're still waving their hands all over the place as they jabber. And for children with autism, this just is not coming in as it should. So along with all that, these kids do have difficulty in developing and maintaining relationships appropriate to their developmental level. They might do pretty well at bonding with their parents. In fact, I find that many children with autism are very affectionate with their mom or their dad or both, and maybe quite clingy to that parent, actually. That parent may serve as their window to the world, and I think the children often sense how much they need the parent. But you try to move beyond that so that you as therapists in the home are trying to build up rapport and get some therapy going with this child. And you all know how challenging it can be with kids on the spectrum, how you have to get to kind of learn their cues, follow their lead, find out what their triggers are so you don't upset them, etc. It's a challenging process. You folks are quite good at it, but again, it's not that natural, easy process that it is with most toddlers. Okay. And then when you make that even more challenging, looking at how these children are relating to other toddlers who are not going to stand still and just wait around for these kids to respond, it's even more of a challenge. So you folks had, I hope, the opportunity to look at a couple of videos that I had sent out before this presentation. And I think the video on Ben and Nathan is a very nice illustration of the social communication impairment that we see among children with autism spectrum disorder. The child the twin, who ultimately went on to get a diagnosis of autism, Nathan, didn't look terrible. He just was not quite as well related as his brother Ben, and he needed a lot of support. You can view that video and many others at the CDC Actorly site, which is listed on this slide. And I encourage those of you who have not yet had the opportunity to get very familiar with early signs of autism to go to this site and look at a lot of those videos. I can talk until I'm blue in the face about what this looks like, but there's nothing like seeing pictures of this. Okay. The next category is that restrictive, repetitive patterns of behavior. This is often a little bit more obvious, and here you have to meet 2 of the 4 bullet points that I'm about to present in this category. So the first is that stereotyped behavior, that those motor movements, those stereotypies, like children who might flap their hands repetitively or might use objects in a stereotypic way. So for example, taking a bowl and spinning it, even though that's not the intended use of the bowl. And remember, in this category, kids can also have repetitive speech. I recently saw a little boy who didn't have too many repetitive behaviors, but one thing he did frequently through our evaluation was just say, ha, ha. It was a little unusual and startling, and it had no clear communicated intent. I have no idea why he was doing this, but it was clearly a repetitive behavior of his, and it was not functional. Okay. So as you know, these children also can have excessive adherence to routines, very ritualized patterns of verbal or nonverbal behavior, or resistance to change. Now, toddlers in general are fairly ritualistic creatures. Any parent who's gone through bedtime routines can attest to that. But this is, as you know, even more excessive among children on the autism spectrum disorder, or at least it may be for any given child with autism spectrum disorder. Some of these kids are really, really rigid, and this often manifests as difficulty with transitions, becoming very frustrated, significant tantruming, and sometimes a lot of anxiety too. These children are not always happy campers, and they really need our help. Okay. And the children as well may have highly restricted and fixated interests. This isn't always as obvious in toddlers, although it can be. You may have a child who's lining things up a big part of the day or stacking blocks to the point that they get to be really, really good at it, but they're not doing much else. And then as children get older, they may have other fixated interests, such as the video that you had available of the little girl who was very fixated on math. Okay. And finally, in DSM-5, the Academy of Psychiatry included sensory issues, which our occupational therapists and others out there so well know is very, very prevalent among children with autism spectrum disorders. And this can present in all kinds of ways. Children who are hypersensitive to certain things in the environment, such as noise, but may be hypo-responsive to other things in the environment, such as deep pressure. So they may kind of pound on things to seek out even more of a pressure sensation. Very variable, but often present, and again, an area that children and families need help with. Okay. So that's a brief overview of the DSM-5 criteria, but you know, when I think of early signs of autism, the first thing I think about is joint attention. And as you know, joint attention is the child's ability to share their interest, pleasure, or maybe their displeasure with something in the environment with a significant other, usually mommy. Okay. And there are many linguists who feel that if a child doesn't develop joint attention, they're not going to be able to develop language. So again, joint attention is something that starts very early with a young baby who's already smiling back at you, and it gets sophisticated very early. I'm always amazed that by 8 months of age, children are already able to do gaze monitoring, which means they're able to look where mommy's looking. If mommy's looking out the window, the child understands that and knows that they should look out the window because there's probably something interesting going on. Already very sophisticated development at such a young age. And this progresses rapidly to the point that by 14 months of age, young children are already able to socially reference. They can read other people's faces, especially their caretakers, mommy. So that if a child's about to trash mommy's briefcase when she comes home from work, the mother doesn't have to raise her voice or necessarily say anything. She can just give the child one of those, "Don't you go there" looks, and the child will stop, at least momentarily, until mommy turns her back. The child can read mother's expression. For children with autism, these things develop more slowly, and they tend to often, even over their lifetime, have difficulty with things like some gaze monitoring and social referencing. Okay, and you can see if you flip back and forth between our standard slides on social milestones and those joint attention milestones that I just showed you, that they correlate very well. So that joint attention isn't just necessary to develop language, it's really a basis for our social skills, our social emotional development. And of course, all of us in early intervention look at children's play skills, and this is another key area of difference for children with autism spectrum disorders. So we know that infants up to around 12 months of age are very sensory motor little creatures. They're mouthing, handling, whatever they can get into. And children with autism, sensory issues aside, generally do that reasonably well. They're curious and often explorative. And children with autism may also develop some functional play, that is, using toys as they're intended to. So they may roll cars, they may even pretend to do something like feed a baby doll, especially if cognition is relatively intact. But where they really have a lot of difficulty with play skill progression is the next level, when you're getting to symbolic play. In fact, one of the items on the ADOS, what's considered the gold standard assessment of children with autism, is a symbolic play item where we give children a toy car and go vroom vroom with it and roll it. And many children, including those with autism, will readily imitate that activity. And then we do the same thing with the toy block. We take a block, go vroom vroom, and pretend to roll it back and forth. Children with autism are generally stumped with that task. They don't imitate it. Whereas a typical toddler will get it. They'll have a twinkle in their eye, and they'll grab a block, and they make that block a car just as we would expect them to do. It's very cute. And then when you get to higher level imaginative play, especially things like role-playing, the 3-year-olds who are pretending they're a princess or an ugly superhero or whatever, that's very challenging for children with autism, even bright children with autism who are considerably older. Okay. I've enclosed a slide of myths and truths about autism spectrum characteristics. You can look it over, but the one of the main points I want to make here is just the variability, and that autism spectrum disorder is truly a spectrum. When we look at all the signs of this disorder, some children are going to be more significantly affected in that social communication domain, but are going to be relatively easygoing in regarding the behavioral signs that we talked about. And for some, it's just the opposite. Some have all of that. So there's truly a wide range. And you can't just take any one symptom and say a child has it or doesn't have it, and that makes it autism, or it means that autism isn't there. It's really looking at the child as a whole and looking at all the symptoms that all the signs that can be present in autism and putting it all together. It takes a lot of experience to do that, and that's why having children evaluated with interdisciplinary teams that really have had a lot of training and experience in doing this can be very valuable. And I also want to emphasize the last point here about no hope for improvement. First of all, it's important to know that some children do move off the autism spectrum. Studies by Catherine Lord, that she's been doing for over 20 years, starting with young toddlers, show that about 10% of her cohort, now young adults, no longer have any signs of autism. They're doing great. And they've been looked at by very good evaluators. Okay. And then there's another group of children who still have autism but have done well. That group would include my son, people who have gone to college, are working, but still have autism, still face some social challenges. And then there are still many other children who need more support. But even among those children who need a lot of support, children like Zack that I talked about earlier, the right kinds of interventions and family supports early on can make a huge difference, and you can still have a happy outcome. The child still may need supports, but the child can have a happy life. The family can feel good about how things are going if everything is provided as it should be.
All right, thank you, Anne. We do have a few questions for you, and let's see, I'm going to start with Ellen, and her question is, do you have an opinion about why we are seeing more children on the spectrum? Is it because there are more children who actually are being, just more children who are on the spectrum, or is it better awareness that we're just finding these kids who've been there all along?
Thank you. That's an excellent question. That's really the topic. I didn't get into that because that's a whole other lecture. But I think the answer to that is some of those. There's no question that the increased awareness, all the good work that you folks are doing has really led to more children being diagnosed. And also in the 1990s, the criteria broadened. So some of the kids who are higher functioning, like the video of the kindergarten child that I showed you, the one who was so intent on math problems, that child in the 80s probably wouldn't have been diagnosed with autism. She was diagnosed in this era. So that's made a difference. However, we do know that there are environmental triggers that are coming into play as well. Older parenting, okay, both mothers and fathers, in the case of children born with autism, increases your risk a little bit. Certain agricultural pesticides, there's some studies that indicate pollution in general increases your risk somewhat. Not vaccines, however. That's been well studied across the world, so you can assure parents that they can vaccinate their child. But it really is a complex interplay of genetic issues, often genetic susceptibility perhaps to environmental triggers. And we're not very good yet from a scientific perspective of totally understanding how all that works. So we have a lot more work to do in that domain.
Debbie and Melinda have kind of related questions. Debbie's question really refers to is the medical community on board as a whole for early detection? And related to that, are there situations when a doctor would suggest not recommending a medical evaluation if autism is suspected? So I know they're kind of combined but related questions.
Sure. I can tell you that all of the major medical societies, the Academy of Pediatrics, of family physicians who provide primary care for children across the state and across the country, as well as the Academy of Child Neurology and of Genetics, they are all on board regarding early diagnoses. Are all physicians doing exactly what they should be doing in that regard? No, they're not. They have gotten better. Our rates of screening, especially in pediatric practices, have increased dramatically, and physicians are better at being informed about early intervention and actually referring on to early intervention or to special education. But I certainly can't say that they're all doing what they should be, and I think we all hear horror stories about families who say, you know, I tried to talk to my pediatrician about a speech delay. I was worried for the past year, and he kept reassuring me. So there still is work to be done.
We have a couple more questions here. One of them is, do you have recommendations at what age someone should be referred for a medical diagnostic? I guess that's really the gist of that question. So do you have any recommendations there?
Yeah, I think you should refer for a medical diagnostic when you're concerned, okay, for a few reasons. First of all, I knew that often early intervention providers want to give the child a bit of time to see how things are going before they might refer. But the way things are in the system right now, you're going to get that time because children wait for months for that medical diagnostic evaluation. They usually wait at least a few months. Some children are waiting 6 months or even longer for that diagnostic evaluation. And believe me, we're happy to take cancellations at our site if parents call and say, you know, our child's improved so much, we don't think he needs it. We've got plenty of other kids waiting for this slot. It's not an issue. But I'd rather them be able to get in as early as possible. Even if we don't make a diagnosis, sometimes we'll see children who are very young, maybe a 14-month-old, and they've got a lot of signs of autism, but geez, they're so young, and we don't have a lot of follow-up data of what autism signs presenting in a 14-month-old is going to look like down the road. How well is the diagnosis going to hold up at that age? We do have that data for 2-year-olds, by the way, but it's not all there yet for 14-month-olds. So there I might hedge a little, talk about this could be autism spectrum. We're going to get all the supports in place. You've already got most of them in early intervention. I want you to think about this and that, and you know, we can work on things. And a lot of times, I think that can really help the early intervention team too, especially if it's done right. I've had many parents who come in and they just thought it's just speech, it's just speech, it's just speech. And then when we start talking about, no, it's more than that, then all of a sudden they're willing to let the occupational therapist get involved, or a social worker, or other supports that could really benefit this child and their parent. So sometimes it can just be, we can just serve as a second voice that's telling families what you're already telling them. But sometimes, you know, they might need to hear it again, and in order to really comprehend it and to act on it. It's always hard to hear that our children are having challenges. It was very hard for me when my son was young. You might think that I diagnosed him by 3 weeks of age, but that wasn't true at all. He really wasn't diagnosed as early as he should have been, and I was already a developmental pediatrician when that child was born. But, you know, my innate mom nature and some denial crept in, and I didn't want to hear the autism word. It took me a while to come to terms, and thank God some of my colleagues were very open about it.
Really appreciate your personal reflections on that particular question. I'm going to take one more question here, and then we will move on. Robin is wondering about the phrases of a child be low on the spectrum or high on the spectrum. What do these mean, and how do you determine?
Yeah, you know, I think we have to be very cautious with that phrasing, especially at such a young age. You know, the ADAS assessment actually does kind of rank severity or functional impairment level. And I will often include that in the reports, but with the caveat to the parents, hey, this is just the results from one test. And we have to take this with many grains of salt at this age. And I really think what's more helpful is how a child, you know, does over time, how they respond to therapy in terms of being more predictive for their ultimate functional level. And of course, we know that cognition is another predictor, but hey, how do you measure cognition in a 2-year-old? We don't do that very well at all, if truth be told. So again, I think you just have to be very cautious with that. For older children, it can be more meaningful, and often there, you know, high functioning refers to kids who have a normal or at least near normal IQ, and then lower functioning are children who also have intellectual disability. But I'm still really uncomfortable with the term. I mean, low functioning just sounds awful. And, you know, there are a lot of kids out there with intellectual disability who may have autism as well, who are doing well in many ways. And so to describe them as low functioning just doesn't sound very family friendly to me.
Thank you for that. There are several questions that are still posted, but I think you've been addressing them as you've been responding to some of the others. So we're going to move on. If we didn't get to your question right now, we'll try to get to it at the next break. Thank you.
Okay, and I'd also like to point out, if people have questions that we don't have time to get to today, you're welcome to email me. We do kind of a strong email filter at UIC, but if you're emailing me from a standard, CFC site or therapy program site or whatever, it should, the email should get through. And if you really have trouble, contact Susan or Maria and they can forward your email to me. Anyway, so just going to briefly review screening tools. I think most people in this audience are aware that screening tools are brief, standardized assessments that help identify children at risk of a developmental disorder. And thank goodness now, in this day and age, we have most of our screening tools are developed as parent questionnaires, so they are easily administered. Okay, so we'd like you to reflect on this question regarding screening tools. Which one is not a benefit of a screening tool? A, the screening tool identifies areas in which a child's development differs from his or her peers. B, is more effective than observing and recognizing children who may be at risk. Or C, screening tools can provide a diagnosis.
Okay, so we will give folks 10 seconds or so to respond. So find that polling function right there. All right, looks like we're getting quite a bit of responses already, so just keep them coming. All right, a few more seconds here. All right, let's see what we've got. So, oh, there we go, sorry. So it looks like most everybody has responded with C, that screening tools do not provide a diagnosis, and it does look like that is the response that you have underlined here. So I'll let you address that, Anne.
Okay. Yeah, great. I'm glad you're also familiar with that concept. I think we know that, and many of you at early intervention are already quite familiar with the Ages and Stages social emotional screen, which is being routinely used. So you kind of get the idea of how we can use screening tools to identify areas where we may want to have further evaluation or put in more supports. But although we all know, I think, that screening tools do not provide a diagnosis, they merely identify children who may need some further evaluation in the areas that are being screened for. So we know that, but sometimes in practice it's hard not to slip and start kind of speaking in that diagnostic lingo. And I have to say that my discipline, pediatricians, are often a little guilty of that, where they may be making diagnoses on the basis of the MCHAT screen that we're going to talk about in a couple minutes. And sometimes that works, but it is just a screen, so sometimes that does not work. Okay, so I've already mentioned that using a screening tool can help us know when to intervene in a certain area. It can raise areas where a child may be having more difficulty, where we may want to look more into the problem and, again, offer supports or further evaluation. And one of the things I really like about screening tools, and I get a lot of feedback from people who use them and it's helpful in this area, is that screening tools allow a platform for parents and providers to discuss concerns. I think those of you who are working in homes could all reflect on situations where you know a child is on the autism spectrum. The issue is, how are you going to bring this up with the families? Because they're not discussing it, and maybe when you've tried to bring it up, they've gotten upset. So how do you do this? And a screening tool can really, literally offer you the language to do that, because you can look at the responses the parent has given that may indicate the need for further evaluation of the child's social communication and interaction, and use kind of the parent's own words to move that process along for a referral for further evaluation. It opens the door for further discussion. And so it's good practice, and actually it's good, physicians have found it's good business. Families may be upset initially sometimes with screening results, but overall they're grateful and they usually come back later and thank the physicians. I think one of the sad things for those of you who are working exclusively in early intervention is you guys just don't always get that thanks because the parents have kind of sometimes moved on to other systems by the time they realize how valuable the information you gave them and your assistance with getting them to a medical evaluation, how helpful that was. So you may face their initial distress, perhaps even their anger regarding the situation, but you're not necessarily around maybe months or years later when they really come to terms with that and realize how much it helped them. Okay, and we know there's plenty of data to show that using screening tools helps you identify children at a higher rate than if you're just using developmental surveillance. Okay, and so because of this, the Academy of Pediatrics and Health and Human Services have combined and with their Bright Future recommendations to recommend routine developmental screening be done in all healthcare well-child exams at multiple times during child development, and then also that autism-specific screening be done at both 18 and 24 months of age. But they also recommend you screen at any time if a parent raises concerns or if someone else who knows that child has concerns. Okay, so there's lots of screening tools out there. We're not going to be able to go over all of them today, but I just have this very busy slide here to give you an idea of how many are available, more than this actually. We're going to talk today about the MChat, the second one down. We're going to talk about the newer revised version that is valid for children from the age of 16 months up through 2.5 years of age. They're now doing validity studies to see if it'll be valid for children even a little bit older, at least through 3 or 3.5 years of age. But no, right now it's valid up to 2.5 years of age. I also want to bring your attention to the last screening tool on this slide, the CSBS, the Communication and Symbolic Behavior Scales Developmental Profile, Infant Toddler Checklist, very long name. This tool is another social-emotional social communication screener that actually can be used from children from 6 months to 2 years. The reason I have the age of 1 or 12 months on this particular slide is because there was a large study where healthcare providers, primary healthcare providers, used this tool for 12 months old, and it was actually very sensitive and reasonably predictive in screening for children with autism spectrum disorders, even as young as 12 months of age, which is pretty amazing. So some people like this tool for that reason, that you can use it on a very young child. I'm not saying it'll work to screen for autism spectrum disorders on a 6-month-old. It has been looked at for as young as 12 months. But some people also like this tool because it doesn't have the A word in it. And they worry that pulling out the MChat can alarm parents because they'll see the A word, autism. And you do have to explain that, and we'll talk about that. So I hope that many of you are already familiar with this tool. It's actually simple to use. I'm going to go over it very quickly right now because I want you guys to have time for a few more questions. But it's simply a checklist. It can be a checklist that a parent completes. It can be a 2-step screening process, but it doesn't always have to be. It covers tasks in all these domains that can be affected in autism spectrum disorder. And I have a sample of the MChat here for you. That hopefully will come up. There it is. Okay, so that's the first 9 questions. And then there are more, up to 20. So you can see that these are pretty basic questions with yes/no answers. It's perfectly okay for parents who have problems with literacy or are confused about any question to explain the question to them, to read the questions to them, and MChat is available in a variety of languages. Okay. It only takes a couple minutes to score. You can actually buy, software to score it, but it's really easy to score. I usually first look at the answers to 2, 5, and 12, which should be a no. If they're not, I'll check off whichever one is not the no. That'll get the kid 1 point. It's 1 point for each question that isn't answered as you expect it to. And then I look at all the other questions and add up the points there. If there are just 2 items that a child doesn't pass, 2 items or less, the child's passed the MChat. If the child has not passed 8 or more items, you don't have to do any further screening. There are clearly concerns. Please discuss further evaluation and supports with that family. And then, like any test, there's gray areas. So here, if a child hasn't passed 3 to 7 items, you do need to ask some follow-up questions. The nice thing is that the follow-up questions are just specific to the questions or to the question that the child missed. And I have an example of that in here. So example question number 6 on the MChat, does your child point with one finger to ask for something? The correct answer is, of course, yes, but if the parent says no, you ask further questions and you can go down this grid to clarify that the parent really understood the question. If the answer is still no, then you count this as an item that was not passed and score accordingly. Okay, I know I've gone over that quickly, but you can get all this information. It's very well laid out in this website in orange that I have on this slide. I encourage those of you who have not used an MChat to try it on just some typically developing toddlers that you use first, just to kind of get used to it. It's kind of a fun and easy screen to do. And also, this is available online through mchat.org. Families can all go to this site, or professionals, and you can enter in. You can answer these questions online. It automatically will score it for you. If follow-up questions are needed, they just pop up. So that's all very easy. It's really nice. And if the child didn't pass it, it will tell the parent to get further evaluation for their child. It'll give them some basic information about early intervention or special education. But it does tell families their child is at higher risk for autism. So I don't usually just send parents off to do this on their own, because if they're getting information that even hints at autism, I like them to be with someone who can support it and put it in context. Because although almost half of children, it's pretty incredible really, almost half of children who screen positive on the MChat ultimately end up with a diagnosis, a little over half do not. Most of the children who do not have other developmental issues, especially in the communication domains, but not passing an MChat doesn't mean you have autism. So again, I think that it's really important for parents to understand this is not a diagnostic test. This is just to try to get more information about social communication and interaction needs and help determine if further evaluation is needed. I want to point out that if we all did the screening, if all primary care sites, child care sites, anyone who touched children did the screening, we would lower that average age of diagnosis from 4 years to 2 years. Pretty amazing. So we have work to do. Okay, so I think it's really important to kind of destigmatize any tool that does have the A word, MChat, the modified checklist, okay, for autism, to destigmatize it a bit. So I like to present the tool as something that we do for all children. This is just screening that all children get. We want to look a little bit more at the child's social communication, social back and forth interaction. And that's how I explain it to families. I just say this is just such an important area of development that we just need to look at this more for all kids, okay? And then if they do question the A word, I basically tell them what I just told you. Okay. When you have to deliver screening results to parents, you guys know how to do this. I think better than most of we docs do. You guys are within the home, with the parents. You know the importance of starting out by emphasizing strengths. I think one of the nice things about using a tool like an MChat, again, is that it can validate a parent's concerns. Parents often worry and wonder what's wrong with their child. They don't know how to put a name on it necessarily, or they're too afraid to put the name of autism on it, but they are often worried. And so you can validate their concerns, not necessarily by saying autism, but say, you know, Ms. Jones, I noticed that, you know, you're reporting here that your child isn't responding when you call his name. We're seeing that too. And you've talked about how he isn't really pointing yet. You know, I think we ought to look more at this. I hear your concerns. So you echo what they have said to validate the MChat score and to validate the reason why you're referring them for further evaluation. And it's really important to be optimistic. You know, just this week, I was talking to a service coordinator, and her team had just done an intake evaluation on a child who was about 2.5 who clearly had autism, seemed to be pretty significantly impacted. And the mom with tears in her eyes looked at the team and said, do you think this is autism? And the service coordinator said, everybody just instinctively looked at the floor. They just were all kind of struck dumb, and I'm sure they were all kind of hoping someone else in the team would answer the question. And I certainly can't say that I've never been stumped by parent questions like that, but I think that it's important to tell parents that, first of all, that you don't yet know from the screening, but you'll help them get that information, and that we can help their child, whether their child has autism or not. Okay? So I'm going to end here. I have just some other slides that talk a little bit about evidence-based autism treatments and other resources, so you can look those over at your leisure. I think we'll open it up for a few minutes of questions.
Okay, kind of scrolling through the questions, and a lot of them had to do with the screening tools and who could do them. So just to clarify, for the MChat, parents fill it out, but with the support of professionals, meaning EI providers can help parents fill that out and support them with that. Is that correct?
That's absolutely correct. And in some early intervention systems in this country, Connecticut, for example, all families complete an MChat if their child is in the system at 18 and 24 months in order to assist them with diagnosing children early when appropriate. And it can be administered to anyone on the early intervention team. Any of the therapists are well qualified to do this. I think it's a great tool for developmental therapists to be using, because developmental therapists are usually a part of all of these evaluations, so they're really there for the families.
There is a question about the screening tool for autism in toddlers and young children, and wondering if you've had any experience with that particular tool as well. I mean, I think that was on your list.
I have not had personal experience with that tool. The data indicates that that is a valid tool, but I have not had personal experience with it. If you have any particular question about it, I'm happy to do a little research for you and try to get back to you about it. So just email me.
I'm scrolling through the questions that you have, and a lot of them had to do with the MChat and how to administer it and who can administer it. And I'm looking through, let's see. Erin has a question that she's heard the following questions from parents. My child is already getting DT, speech, and OT. Why should I pursue a diagnosis for my child?
Great question. For at least a couple of reasons. First of all, sometimes the diagnosis can tie in other health-related or genetic issues that a family should be aware of for their family. Even a child such as Benny, that one case scenario, that was a really healthy little boy. He was not sick much. He looked great, and yet he had a very serious, potentially very serious medical issues that needed to be taken care of. So that sometimes happens. But the other reason too is that a diagnosis can help parents have further understanding of what is going on with their child, and they may choose to add other services sometimes through private insurance or seek out things in the community, like at the Autism Resource Centers or support groups, to learn even more about what to do for their child. So yes, they're getting lots of great information from the developmental therapist, speech therapist, and occupational therapist, but there is just so much to know, and only so much time that you folks have with a family. A lot of times you're not really getting these kids till, they're about 6 months from graduating from the system. So, I think we need to bring in everything we can to play for these families because they need the help. Zack's mom, I talked to her just a bit before this presentation, and she said, please tell them. Please tell these providers that an early diagnosis is so important. It meant so much to me because it allowed me to go out and get the answers and really be able to understand my son, to learn about all the different strategies, and to really embed them in his everyday life. And I know, again, that's the goal of what you guys are already doing out there, but again, you only have so much time to do this. I want to emphasize it takes a village. It's I think often more, I mean, not for all kids, but for many kids with autism spectrum disorders, it's more than just one system can do. It takes everyone working together.
Martha was curious as to whether or not there were any videos or resources out there of children being administered, say the MChat or any tools, who are responding as a typical development. Her question has to do with the fact that sometimes parents want to see what it should look like, and to compare kind of what they're seeing with their own child. Any thoughts on that?
Yeah, there's actually a really nice DVD that was developed by, I think the project was called First Signs. It's called Learn the Signs, Act Early. And if you Google that, you'll probably be able to just access it. And it's not actually showing an MChat administration, but what it does show is a lot of these areas, the difficulties in social communication that I was just talking about, and it contrasts the child who, and these are really young kids that they're looking at in this video. Some of them are only about 12 months old. And they show little video clips of a child with typical development and then immediately contrast it with a child who is at risk for autism spectrum disorder. So you can really see those subtle differences in that video. So I would recommend that. It's Learn the Signs, Act Early. Learn the Signs, Act Early. If you're finding it, again, email me. Maybe, Susan, I don't know if you guys can put out a link for that. Okay.
I'm kind of looking through the rest of the questions, and a lot of them really just kind of have to do with the medical diagnostic process. And so if I can just kind of reiterate what you said, and please correct me if I'm wrong, but you would prefer that if there is a suspected, a child that has suspected autism or on the spectrum, to make the referral for medical diagnostic and cancel if it doesn't follow through with if the child doesn't seem to have any. Okay, I can't speak anymore.
That's fine. I think you've captured it. If the child does make great improvement, and all, 6 months later, you're not worried about that child's social communication, perseverative behaviors, whatever, that's wonderful. Congratulations to all of you for your great work, and feel free to cancel. No problem.
All right. Well, it does appear that we've covered, I believe, most of the questions. A lot of the things in the chat box are really more statements and a lot of support to each other. Obviously, this is a very big topic, and I'm sure Ann could go on for days about this particular topic on a variety of different tangents. So I think we'll go ahead and wrap it up if you want, Ann, and have final thoughts.
Be fine. Thanks for having me here today, Susan and Maria. And again, people feel free to send me any questions.